So, without further ado, I introduce to you my CEO, Ms. Sheila Schweitzer. She is the founder of PatientMatters, a company focused on assisting healthcare organizations in the management of the patient obligation. Prior to PatientMatters, Ms. Schweitzer was CEO and chairman of the board for CareMedic. Under her leadership, CareMedic achieved a lead position in the healthcare IT revenue cycle market, where they successfully brought to market the first enterprise-class revenue management system, the electronic financial record. Ms. Sheila, are you ready?
I'm ready, Betsy. Thank you.
You're welcome. Take it away.
And thanks, everybody, for joining the webinar. What we're going to talk today is about what has recently become the third largest payer for most hospitals and health systems. Okay. Betsy, do I have control? There we go. So let's define who is your third largest payer. Since the introduction of and really the embracing of high deductible health plans starting around 2008, the patient in its entirety has become most hospitals and health systems' third largest payer. So if you're wondering who we're talking about, we're going to talk about the patient and the obligation that they're incurring for their cost of care. Here's the situation. Patients are responsible for more and more of the cost of care, and if you can believe the studies that are out there, that's only going to continue to grow over the next several years. So the situation has changed dramatically around the patient and how the patient is going to pay for their care. And that means that hospitals and health systems have to change as well. It means that staffs are going to need new skills to deal with this change. There's going to have to be new methods, new processes, new infrastructures because the complexity of this environment is new. And hospitals going to need more insight, not just more data. So that's what we're going to talk about today is how has the responsibility grown? What does it mean to hospitals, and particularly the yields on payment, and what you have to do to be more effective? I like this next diagram because it's an Oliver Wyman assessment. It's 2010, but if you look at this, you can see that in 2010, $125 billion for hospitals had to be collected directly from the consumer, and that was only for co-pays and deductibles. So if we believe what we're all hearing, that those co-pays and deductibles are going to grow by about 40%, you're looking at another $500 million, pretty substantial for hospitals to deal with. And it's not just the uninsured and the self-pay patients anymore that hospitals have to look to make these payments. If you look at the insured, this is a sample from 2002 to 2010. If you look at the growth in the cost to the patient for their services, it's grown by 124% from 02 till 12. If you look at individual plans, same rise in obligations from the patient, about 71% up to 80% for a family of 4. So I don't think anybody will deny that the patient's financial responsibility really is becoming forefront in hospitals and health systems. And so the answer is now, since this really is the problem, how are we going to address it as an industry? Because the poorest performing payer traditionally is now the fastest growing. So we have to think differently, act differently, and it requires a different infrastructure. Here are some interesting facts. 55% of patients' responsibilities are never recovered, and if that's true self-pay, about 81% of that never is recovered. And it costs hospitals 2 times to collect from a patient what it does from an insurer. So this is something that can't be ignored. It has to be dealt with. Let's talk about the impact of what happens when the shift goes from an insurer to a patient. Let's look at the first column, and you have a $10,000 charge under traditional managed care circumstances. Normally, the insurance plan will pay about $7,200. That leaves the patient about $2,800. If the hospital is collecting from the patient at a 32% rate, you're seeing an 81% yield, which is really good and comfortable. But let's look at what happens when that person is insured in the silver plan. That same $10,000 with that same collection percentage, the hospital is only yielding 75.5% out of that $10,000. Let's go over to the bronze plan, which is the second most utilized plan in the Accountable Care Act. Under those same circumstances, that hospital will only have a 56% yield on that $10,000. So the point of this is you can't ignore the patient's portion of that $10,000 anymore. We have to learn how to be effective, to educate the patients, to change the paradigm, not only for the patient but also for the hospital. So how do we recommend you do that? This is a really interesting statistic. As an industry, as a society, we have pretty much taught patients not to pay their health bills. So this is a study that was done annually. So for patients that do pay their portion of the bill, 75% of those that do pay on bill 1. That drops to about 25% will pay you on bill 2. But a lot of the payment comes when you have to move to bad debt collections. So that means you've expended time, cost, and energy to try to get that patient to pay. So the whole point is we have to unlearn the patient's behavior of healthcare payments. Now, how are you going to do that? You know, the conversation between your staff, a hospital staff, and the patient, it can be an uncomfortable conversation if the staff isn't equipped to really understand that patient, understand what that patient's going to owe, and then have the opportunity to assist that patient in paying for their bills. So the whole point here is turn that uncomfortable conversation between the patient and the registrar into an opportunity to educate that patient on why they owe, not just what they owe, which has been the traditional method. So we talk about that the staff has to change, the staff has to be properly equipped. So we're thinking that it's important that as a health system you begin to know your staff, understand the behavior of your staff, and perhaps it will end up that you will realign some of your staff, people who can be comfortable talking to a patient about their financial obligations, not only their care, can still be supportive and caring, but can have that conversation. The only way we can get the staffs comfortable and change that to an educational conversations from an uncomfortable conversation is to change their workflows, give them the data, really have a profile of that third largest payer, which is your patient. So we're going to talk about processes, workflows, and what kind of infrastructure does it take. This is typically what happens in the majority of hospitals today. The patient receives care. About 10% of the obligations are collected before or at the time of service. Then 3 bills are sent, and then you begin to turn that patient over to either an early out vendor or a collection agency. And if you go back to the diagram of how we've taught patients to pay, you'll see that the bulk of it was done in the aggressive collection process. A lot of that is because the patients just don't know and understand what their costs are, how much they're going to owe. 68% of the time, they don't know it until after they've been treated, and very often it can be 60 to 90 days post-treatment before they really begin to understand. This is normal. This is the way it's gone on for years, but we can't do that anymore. The impact to health systems is too severe. We have to learn to deal with the patient. We have to understand the patient as a consumer. So what we have to do is really, we have to flip that paradigm. We have to have informed data. We have to have a registrar, a point of service registrar, comfortable with the conversation, confident in the patient profile so that they can talk to that patient effectively and lead that patient through the payment process. What's it take to do that? It takes more than just siloed technologies. As an industry, we've done very well having a full profile of a third-party claim. You know, me included, it took the industry about 30 years to be able to effectively file a claim, understand everything about that claim, and never lose track of it. We haven't, however, done that on the patients. It's important that we build a consolidated patient financial profile so that we understand that patient's obligation, we understand and give that patient the opportunities to pay just like we do an insurance payer. So you can't have siloed data. You have to have all of these processes in a single format so that what you're really doing is building the financial profile for that patient so the staff and the patient both understand, one, their obligation, and two, the best way to allow that patient to pay. What we at Patient Matters call that, we call that optimizing the patient's pathway. And this really is just a workflow of how we can take that patient, and with each step in the process, we began to know more about that patient so that we can be very effective, very comforting, but very sure of the dialogue we have to have with that patient to get them through the process. Whether that is financial counseling, to take them through a Medicaid program, an enrollment on the exchange, a county program, or a true charity patient. Also, we have to, as an industry, give these patients more opportunities to pay. We have to take them through social media, text, allow them to pay online, electronic signatures, develop payment plans. Also, financing the patient's obligation is something that we feel is very important to allow patients to begin once again to utilize elective surgeries and not put off important health procedures because the fear of the obligation. So this is how we optimize the patient's pathway. The important thing here is that We have the hospital staff, they understand, we guide them through the process, we take them down the right path that's most beneficial for the hospital and for the patient. Now, we're a huge believer in the MAP keys. We think the MAP keys are a really strong barometer that hospitals should use to evaluate their performance, but we think the informed data has to go deeper than that. Hospitals have to have real insight and not just more data. The only way you can really begin to understand all of this is if you have developed that patient profile. And then you can begin to do trending, and you can understand your patients, those that frequent a hospital, how we can deal with those. So you really begin to look at your patients on a day-by-day basis and understand where you're going with that. This is a sample of a bad debt summary. I'm going to show several of these. But bad debt is one area that we really believe there's an opportunity. In one of our partner hospitals, when we began to trend and understand their bad debt, we recognized that just under 30% of their total bad debt were patient wage earners of 6 figures or greater. And most of the time, it's not that these patients are unwilling to pay. It's just the process is broken, it's fragmented, patients don't understand, so they end up in bad debt. So our view is informed data, informed staff, change your patient's behavior. Just another example of some trending to understand the bad debt data. So when I said in the beginning, the patient's your third largest payer, staffs need new skills, new training, comfort to have conversations with the patients. Also, you have to have new processes, new workflows that are data-driven. You can't just change a process and ask a registrar or ask the staff to do more. You really have to have informed data so that the processes and the methods are really positive for your staff and for your patients. We believe these are the processes that are appropriate to maximize the patient's obligation, collection of the patient's obligation. The first thing you do is ensure that the patient is informed and the patient understands their financial processes, just like you take the time to understand their clinical processes. Then we do have to manage the uninsured. The uninsured is a population that you have to look at very carefully, understand, help them through the process so that you do maximize the payment options. Staff effectiveness, you have to leverage the people. Now that you have the data, now that you have a patient profile, you really have to understand your staff effectiveness. It takes constant interactive training, dynamic scripting. We recommend a hospital considers incentive bonuses, performance awards, and you always have to have constant reporting and measurements so that you can tell where you are in the process. A little earlier, I showed you some birds to talk about how do you effectively know your staff. We think it's important that you truly do know your staff. Some people can be more comfortable in this type of an environment than others. So at PatientMatters, we have what we call the BIRD program, which is really just a very fun way to understand a human being's behavior. We know some people are better at at pre-registration. Some people are better in other scenarios to talk to that patient. So I don't need to read you these entire processes, but the important point here is that your staff needs to be looked at differently. They need different training, different processes, different methods to deal in this new environment. The only way, effective way to do it is to be data-driven, so that your processes and your data needs to build that patient's profile. It's not good enough anymore to do an insurance verification and perhaps after the fact do an analysis to understand who might pay and who might not. It has to be a continual look at that patient as a human being and understand their situation so that you can be effective in collecting their obligations. We've been doing this for a while now, and we believe that if you do the right training, mentoring, understanding your staff, you'll pick up about 30% of your benefits in that arena. If you do workflow and metrics that are managed with informed data, you'll get about a 35% improvement. And then technology and information brings another 35% to the process. So any one by itself is somewhat effective. All three of these programs together is where you can really maximize the benefit. It improves employee morale, it improves patient satisfaction, and it proves to be financially beneficial to the hospital. So we think there are 6 steps to be successful in this new environment. It's critically important that the leadership of the health system or the hospital really understands the need for employee education, employee involvement. This truly is a culture change for most hospitals. So you have to really focus on your hospital, your staff, be prepared to have those conversations with the patient, and they need to be underscored with reliable data. So you have to understand that patient, because that patient is just not a statistic as they come into your organization. Consistent processes. Things like, social media. You do have to bring automated patient opportunities. You have to bring in automated estimations. You have to give that patient multiple payment vehicles. And then, of course, you do have to measure, report, manage, have strong data that can give you the opportunities for improvements so that you truly can change the culture. Okay, I've gone really fast. I hope some of you have questions.
Sheila, I actually do have a couple of questions. One person typed in, I find the bird thing interesting. Can you tell us who is the best at collecting money?
Yes. An owl has proven to be the most effective in really understanding the data, taking the data and being able to turn that into an effective conversation with the patients. Peacocks are next, but an owl or a peacock are truly the most comfortable in that environment.
All right, I've got another question.
I don't know who. Well, I don't know who asked that question, but have you ever thought of getting to know your staff that well through some type of a program like this? If you ask that question, I'd like to know if you ever have.
Okay, we'll see if they respond. I've got another one. HFMA has been talking about patient education lately. How much of, how much is that a part of your program or service?
It's a very integral piece of our program, because we know that as an industry, we have really taught patients that it's okay not to pay your medical bills, and that just really can't continue. So we take a great deal of time. We have developed programs. Our partner hospitals, we work with the senior staff, the CEOs, the CFOs, the medical staff. We have programs that we teach them for them to go out into their communities then to talk to not patient organizations, but talk to organizations in the communities about, the changes, the impact of the impact of this change and how it affects the patient and the community and the hospitals. We do programs like we develop educational programs in the community so that we teach the senior executives of the hospital how to hold educational forums for small businesses, large businesses, so that they can understand the impact of the Affordable Care Act, what it means to them, what it means to their employees. So yes, education both inside the hospital and in the community is a very big piece of what we do.
All right, and before I ask you the third question, which is the last one, I have another one too, so we have two more. I have three more. All right, so what data are most hospitals missing that you currently see?
A lot of your hospitals might have the data. What the difference is, they have it in siloed environments because of point solutions. So they don't build that complete financial profile for a patient by just continuing to go through the normal processes that you do with the patient. Secondly, when we partner with the hospital, we actually shadow their data. So we can take the data that they use to drive their business and begin to trend it, begin to do things like scoring patients. We can do predictions on what the change in a large employer moving to a high deductible health plan. We can begin to trend what that is going to mean to the community, to the hospital. So it's not that perhaps we have more data. We have the ability to use the data differently.
All right, I have another question. What is early out and how does that work?
Early out is a relationship between an organization that does the collection process for hospitals. They do outreach to their patients rather than the hospital staff doing follow-up and answering questions. It's a vendor relationship.
Okay, and the last question that I have...
Do you have another question, Betsy?
I do. The question is, does asking for money up front have a negative impact on patient satisfaction?
I think if you ask for money without having the ability to walk that patient through why they owe that, not just what they owe, can have a negative benefit. If the staff is not comfortable really understanding how much that patient's going to owe through this infrastructure, it can be an uncomfortable situation both for the staff and for the patient. If the staff is informed, they're confident in the data, they're comfortable that the data is right, they fully understand it, they understand the patient's obligation and why that patient owes, it can become a very positive situation and improve patient satisfaction.
Okay, and this question actually is from the person that asked the question about early out. They want to know if Patient Matters will include collection services.
I want to quantify if that is bad debt collections. Patient Matters is not a bad debt collection agency for a lot of reasons, but we have a partnership with the bad debt collection agency.